Emergencies. That's the chapter for today. And then after the lecture, we do have a Cahoots test, like we're going to have most nights. All right, so just the general anatomy of the vessels that surround the heart itself and the heart. We should know most of this by now. So obviously the top chambers, these two are your atriums. Lower chambers are your ventricles. The left ventricle being the biggest one of them all. And again, you have your vena cavas. Sorry, I'm going to be pausing every now and then to admit people in the classroom. So if I pause for a little bit, just because I have to admit them in. All right. Let's see. All right, so you have your vena cavas, your superior vena cava, inferior. Obviously, these bring blood back to the heart, and that's blood that's been used. So that means the oxygen has been given to the tissues of the body, and it's coming back to the heart to receive more oxygen. And this right here is your pulmonary. Wait, okay, here we go. So it's more visuals and more pictures and more names of everything. So you have your pulmonary arteries that take blood away from the body, from the heart and to the lungs to get oxygen. And I just skip the anatomy. You guys can review this if you have time later on. All right, so how does the normal function of the heart and blood vessel relate to blood pressure and distal pulses? So I'm going to go ahead and just pick on somebody to answer this one and also the following question. So Michaela, can you answer that first question for us on the first bulletin, please?
All right. How does the normal function of the heart and blood vessels relate to the blood pressure and distal pulses? Well, if it's like a normal function, then you're going to have like a healthy pressure coming out. But I mean, if your like blood vessels are like constricted or like dilated, then it's going to make the pressure lower or higher.
Yeah,
and you're going to be able to feel the pulses better or less.
exactly. Yeah. So if you have a normal function of the heart, then every time that left ventricle contracts, pressure is going to rush through the vessel, and that creates that distal pulse, right? That's every time that left ventricle squeezes blood into the aorta, that creates a wave force that allows us to feel that distal pulse. And then the blood pressure too. Every time that left ventricle contracts in the heart, that pressure that rushes through the vessels creates the blood pressure that we read also. Good job. See, Drake came in. All right, let me see. So the next question, how is shock related to the function of the heart and blood vessels? Who wants to just go ahead and volunteer for this one? For that last one. Let's see. All right, I'm gonna go ahead and just pick on Drake. Can you rough your way through this one? The second bulletin. How is shock
related to function of the heart and blood vessels?
Yes, sir.
So shock is just the heart not functioning, right? So the heart is just not adequately getting blood through the body, so through the blood vessels.
Yeah, so if the heart, if that left ventricle, for whatever reason, there could be many reasons, but if that left ventricle isn't pumping adequately, then that pressure in the vessel, that blood is not gonna go fast enough, and that leads to shock because now blood is not traveling through the body at the rate that it should be to supply the O2 to the body, right? So now that's gonna lead to shock because that pressure is going down. The speed of the blood is going down, so we're not delivering nutrients and oxygen to parts of the body. And then as far as the vessels go, relating to shock, the vessels you have what's called anaphylactic shock, right? Which that's a severe allergic reaction. And one of the side effects of that is that your vessels dilate. And so if your vessels dilate, it doesn't matter if your heart is pumping good. If your vessels get really, really big, then the fluid level, the blood level goes down, and the vessels bringing that pressure down, which leading to shock ultimately. And that's just one example. The other example would be like neurogenic shock. So with anaphylactic shock, neurogenic shock, and septic shock, with those three types of shock, is the exact same issue. There are different ways of going through shock, but the outcome is the same, and the outcome is that the blood vessels get really big, which drop, they dilate, which drop the blood pressure down. And if the blood pressure is down, that means that the blood is not traveling fast enough, and that in itself is going to lead to shock. That makes sense, guys, or no? Good?
That makes sense.
Yeah.
All right, cool. I'm assuming it makes sense.
What
All
was
right.
the third one that you said? Sorry.
Okay, as far as the shocks, you have anaphylactic shock, you have neurogenic shock, and you have septic shock. Septic shock, think like a septic tank, like a poop tank. That's the same concept. There's like a waste in the blood, and the waste that's in the blood is what actually causes the vessels to dilate and become permeable, leaky. Okay, so let me. All right, so now we're going to talk about acute coronary syndrome. Who here remembers what acute coronary syndrome is, or at least kind of have a kind of an idea of what that is?
It's kind of like any kind of coronary problem, right, with the heart? Like any kind of angina or heart attack or anything like that?
Yeah. So it follows along those lines. So in general, what's going on with the acute coronary syndrome, you have either a partial, it's a partial or almost complete obstruction in a coronary vessel. So yeah, so that's when you get angina, you can get that chest pain because there's not enough oxygen going to a certain part of the heart. Now, see, acute coronary syndrome, so it's sometimes called cardiac compromise. So I mean, it's pretty simple. Compromise means something's compromised. That means that it's not functioning how it should be functioning. That's one way to look at it. See, it refers to any time the heart may not be getting enough oxygen. We talked about that. See, the next bulletin, many different kinds of problems under ACS. Yeah, so acute coronary syndrome. So what this means by definition, acute, every time you see acute in the medical field, think fast, like sudden, it just happened. So this just occurred. So acute coronary syndrome, that means that there is an issue in the coronary vessels, in the heart vessels, and it happened pretty fast. That's just kind of what it means in general. Now, the reason it's not so specific, it's because it could be a number of things that could cause acute coronary syndrome. It's not really tied to any specific thing, so it's a general term, meaning that there's an issue, a sudden issue in the coronary vessel. Who's that? Okay. All right, so sorry about that. Come on. All right. Acute coronary syndrome. Treat all patients with acute coronary syndrome like signs and symptoms of a cardiac issue. So because it is a cardiac issue, so acute coronary syndrome is a cardiac issue because it's affecting blood supply to the heart itself. Chest pain, and we said chest pain when it's connected to the heart is called angina, right? So angina, chest pain is the best known symptom. See, these right here are terms you should want to write down. So under the first bulletin, it says chest pain is best known symptom, can be described as crushing, dull, heavy, or squeezing. So these are your textbook kind of definitions of the feeling a patient should have if they are having a heart attack. Sometimes described only as pressure or discomfort. So from my experience, the patients that don't really feel the pain but feel more of a pressure or discomfort are your female patients. I'm not sure why exactly, but a female patient may not present with any kind of chest pain, but may feel like discomfort or pressure on like their middle back, like on the posterior side of their back, of their body, and it'll be kind of in the center, from my experience. Radiates along arms down to upper abdomen or up to jaw. So if you don't know these things, I would go ahead and write them down. And whenever you're doing your OPQRST, you know, the one we talked about in last class, the OPQRST, every time you do that, you're kind of trying to figure out if the patient has any one of these or not. So radiation, does it radiate to the abdomen, upper jaw? That's one of them. And then as far as quality, that would explain like the pain. Is it crushing, dull, like that? And that's what I'm talking about as OPQRST being kind of tailored for cardiac. All right, dyspnea just means they're having difficulty breathing. So if your patient is in any kind of pain, most likely this is just gonna be something that comes along with almost any medical condition. Let me see, keep going with this. All right, so like I said, your patients, if they are having some kind of pain, they're gonna be anxious, right? So along with anxiety, you also have the dyspnea, which means difficulty breathing or labored breathing, feeling of impending doom. See, nausea, pain, and discomfort in the upper abdomen. So that's another one. Remember, I said anytime you see epi, that means above something. So right here in that, the third dot, the second square going down, epigastric pain, all that means is that you have pain right below your chest on the upper part of your abdomen. Sudden onset and sweating, that one's another red flag. So if the patient wasn't doing anything at all, they were just relaxing or doing just mild work, like in a warehouse, like closing up a box or anything like that, and they had sudden pain accompanied with sweating, diaphoresis, that's a big red flag of it being cardiac. And abnormal pulses. So for those of you that don't know yet, tachycardia means a fast heart rate. Bradycardia means a slow heart rate. So the actual number for these is tachycardia, and you should write this down if you don't already have it down somewhere or know it. Tachycardia is any heart rate that's above 100 beats per minute. Bradycardia, sorry, let me admit somebody. Bradycardia is a heartbeat that's below 60 beats per minute, all right? And then obviously abnormal blood pressure is another finding of acute coronary syndrome. Now for a patient having acute coronary syndrome, the blood pressure, do you think the blood pressure is gonna be elevated or is gonna be down? Hypertensive or hypotensive? James, what do you think? For your patient going through acute coronary syndrome, so I know you just joined, so I'm gonna kind of give you a little rundown. So acute coronary syndrome, in a nutshell, means that there's not enough blood going to a certain part of the heart, right? So you have angina, chest pain. If your patient has acute coronary syndrome, the abnormal blood pressure, you think is going to be abnormally high or abnormally low?
It's going to be low.
Low. Anybody else think differently? And if you do, why? Now, give you a hint. The first one up here, anxiety, kind of gives you a hint as to whether it's going to be high.
Okay.
I'm thinking like high, just because there's like a blockage, so it's like backing up pressure. But I don't know if that's right or not.
You're right. The first part is right. So it is going to be high, and the reason it's high is because the blood pressure relates to the pressure throughout your entire body, right? So and this problem, acute coronary syndrome, I'm sorry, let me. So acute coronary syndrome is only exclusive to the heart itself, right? So that is not really blocking any blood in a major part of the body. So it's not going to affect your blood pressure in that way. So like what I'm saying is that the blockage itself, from the acute coronary syndrome, that is not affecting the blood pressure itself. What's affecting the blood pressure is that your body notices that there's a lack of oxygen to a part of your heart, which in your heart is one of your vital organs, right? You need that to survive. And what happens is signals are sent to your brain to constrict the vessels of your entire body, to increase blood pressure. your heart rate is going to go up instinctually because your brain is doing it for you. And that's because it's just doing whatever it can by itself to kind of pump faster blood and get it to where it needs to go, because obviously there's a section of the body that's not getting it that should be definitely getting it. So that's how it affects your blood pressure. It's like that's the secondary stuff that your body does to kind of counteract however it feels it should counteract. Hopefully that makes sense. I'm not sure if it did, but hopefully it did.
Yeah, that makes sense.
Okay. Okay, so we'll keep going with this one. All right, so as far as the management of acute coronary syndrome, obviously perform your primary assessment. If your patient is having a cardiac issue, or you think it's gonna be they're having some kind of serious cardiac issue, you're gonna notice it right off the bat. This patient will be clenching on their chest because of the pain. It's just like an automatic reaction. Most of them will be clenching on their chest, or they'll be also in the tripod position, trying to catch their breath because they're gonna be anxious at the same time. Obviously, you want to obtain your history. Now, when it comes to history, you want to make sure that it pertains to the actual medical condition that you're there for. So you want to ask any cardiac questions, any pulmonary questions, because the problem for this patient is in the chest, right? So we want to focus on the thoracic cavity and the organs that are in that area. And your heart and your lungs are 2 of your 3 vital organs, and most likely they're being affected. Again, OPQRST, that is tailored for cardiac, and we've gone over that before. And if you have any questions on that, go ahead and ask. Any questions on OPQRST? No? Okay. Again, obtain past medical history and take your baseline vitals. Now, your vital signs, what do your vital signs do for you in general? As far as your patient status and everything.
They give you a baseline so you can see later on down the road whether or not your patient's improving or declining.
Perfect. Yeah, that's exactly what it does. Thank you. Patient care, place patient in position of comfort. Usually for your cardiac patients, yeah, it's always going to be Fowler or semi-Fowler. So sitting up, that's just always our comfortable position for the most part. And then determine if oxygen should be administered. For these patients, your cardiac patients, it's going to be rare if you don't give them oxygen. They're going to feel better when you give them oxygen, just because even though it might not directly help with the obstruction, it will help with the anxiety from that issue. So we're going to put these patients on an NRB, so a non-rebreather mask, between 10 to 15 liters per minute, okay? These patients. And obviously transport them, get them to the hospital ASAP. Let's see, provide high concentration oxygen. I'm just reading the bottom, what it says in the bottom. By non-rebreather mask. Yeah, so our goal is to keep these patients at 94%, okay? So between 95 and 99% oxygen saturation, that's our goal. If you don't know that now, please write that down. So our goal is to have a patient's oxygen saturation between 95 and 99. We do not want to go to 100. If we go to 100%, we're not sure if it's at 100, 110, 130. So that's why we keep it at 95 to 100. Now, the only patients that you want to be careful with at the EMS level are your COPD patients, and we talked about those before. Now, whenever it comes to your COPD patients, if they do have COPD, there is a very, very high chance that they're gonna be on a nasal cannula when you get there already. All right, and you'll know if they have COPD. First of all, you're gonna get a medical history, so you're gonna know that right off the bat, and it's something you have to just keep in the back of your mind every time you're working with certain populations. For them, for patients that are on COPD, I would see what their normal baseline is. So they might be resting around 85, 89. That might be their normal, and just try to get it to their normal baseline, okay? For your COPD patients. But you have to understand.
So you take it without the oxygen that they currently have?
Yeah, so for your COPD patients that they're having like a serious medical condition, because you have your patients that, you just transport. It's like a taxi ride. You just take them to a hospital or a facility because they can't drive themselves. For those patients, just obviously keep them on their nasal cannula. But if your patients are having some kind of difficulty breathing or having some kind of cardiac issue, then it would be wise to shift them over to an NRB, maybe at 10 liters per minute, but keeping a close eye on their O2 set to make sure it doesn't go too high. Does that make sense? What I'm saying?
Yeah. How fast does it change? Like if you take them off their nasal cannula, like how fast does it change to where you get a baseline reading?
That's a good question. It actually takes quite a bit that's my opinion. For your O2 saturation to change, it takes at least, let's see, I want to say a good minute to 2 minutes before you actually see it on an O2 sat. And I wish I could show you that. I actually give you guys an example in class, but yeah, it takes about a minute or two. So, and the reason I think it's a good question is because when it comes to treating your patient, O2 saturation is good for kind of like, making sure that your patient's levels are decent, especially for COPD patients. But I would never, ever go off of O2 saturation to treat my patient, only because 1 minute is a very long time for oxygen delivery. You know what I mean? So this is, I guess, a side note. So it takes about a minute to 2 minutes before it shows on your O2 saturation reading. To answer your question, a minute or two. All right, so let's see. So EKG or ECG. If you're with the paramedic, you're gonna have this, and most likely, if you're with them, you'll be setting up the EKG for them and the lead, and they will put it on the patient and actually read the ECG. But I don't know. Yeah, I think in Fresno, in the Fresno area, there is a lot of BLS and ALS. That's actually how it is. So you guys will actually come in contact with this quite a bit. So that's good for you guys. Let's see. Patient care indications for administering nitroglycerin. So it's kind of a review. Obviously, if they have chest pain, angina, which is what it's called, from cardiac issues. If the patient has a history of cardiac problems, and at the BLS level, at the EMT level, obviously the patient has to have nitroglycerin prescribed to them. Okay, that's the biggest thing. You can't give it to them if it's not prescribed legally. You can't do that. And see, patient has nitroglycerin with them, so obviously that have to happen with them. And then what's the route for nitroglycerin? Anybody?
Under the tongue.
Under the tongue. And what's the medical term for that?
Sublingual.
Sublingual, yes, sublingual. And that's just the tablet version, I think, right there. See, they have the tablet version, they have the spray, and then they also have patches that they make also as well. All right, so continuing on with the acute coronary syndrome. So indications for administering nitroglycerin. Obviously, we talked about the systolic has to be good. So the systolic blood pressure has to be above what? Someone pick on somebody. Andrew, you there?
Yeah.
So what do you think the systolic blood pressure has to be above in order for you to be able to give nitroglycerin? Like, what do you think? It's usually a range between this number and that number, and it's all based off protocol, but it's always going to be between these two numbers, one or the other.
60 to 100.
No, so 60 to 100 is the normal beats per minute for heart rate. Now, for systolic, the blood pressure, that's that top number, right, of the blood pressure. It has to be between 90 to 100. If it's above that, you're okay to give nitroglycerin. If it's below that, you have to call medical direction if you think that you still need to give it. Okay?
Okay.
Again, patient, if they've taken Viagra or any erectile dysfunction medication, and these are your new hours, so they've actually changed from 3 years ago. So if they're taking any erectile dysfunction medication between 48 and 72 hours, they are not to take nitroglycerin. So if you don't know that right now, I would write that down. if they've taken any kind of erectile dysfunction medication, 48 hours to 72 hours, they are not to take nitroglycerin. And that's because, again, Viagra and any other erectile dysfunction medication, they are also vasodilators. And we do not want to stack these vasodilators on top of each other because it brings the blood pressure down to dangerous levels, and which could lead to shocks, obviously.